Concepts 9. Acid-base balance. Definitions. The process of regulating acid-base is through pH, bicarbonate concentration, and partial pressure of carbon dioxide of body fluids. Acid is a substance that releases hydrogen ions. Base is a substance that takes up hydrogen ions. Acid production is generation of acid through cellular metabolism. Acid buffering is a process to control changes in pH by neutralizing acids with buffers. Acid excretion is removal of acid from the body. The most important base in the body is bicarbonate, known as HCO3. The pH of a solution is a measure of its degree of acidity. A low pH means the solution is acidic. A high pH means it is a basic or alkaline solution. Other key terms: acid production is the generation of acid through cellular metabolism. Again, acid buffering is a process to control changes in pH by neutralizing acids with buffers. The most important buffer in the extracellular fluid is the bicarbonate buffer system. Acid production and generation of acid through cellular metabolism. Increased cellular metabolism produces more acid. Acid excretion, or removal of acid from the body. Carbonic acid is converted to gases. Metabolic acid is not. The lungs excrete the gaseous form of carbonic acid, and the kidneys excrete metabolic acid. When the bicarbonate to carbonic acid ratio is 20:1, the blood pH is in the normal range. Acid production occurs constantly within the body. Carbonic acid production comes from cellular metabolism, which generates carbonic acid, which is H2CO3, in the form of carbon dioxide and water. Bicarbonate in the blood is transported to the lungs and capillaries where the CO2 level is low, because CO2 diffuses into the alveoli and is exhaled. The lungs serve as the excretory organ for carbonic acid. The kidneys secrete metabolic acid but are unable to excrete carbonic acid. The scope of concept: acid-base balance can be viewed as a continuum. Optimal balance is seen in the middle, and extremes of imbalance are on each end of the spectrum. As you can see from the arrow, optimal pH is 7.35 to 7.45. The PaCO2 and the HCO3 are normal. Acidotic is pH less than 7.35. Alkalotic, to the right of the arrow, is pH greater than 7.45. Respiratory alkalosis occurs when hyperventilation excretes more carbonic acid. Respiratory acidosis is when hypoventilation excretes less carbonic acid. The normal range again for pH is 7.35 to 7.45 in adults. It is a little wider for infants. H2CO3 breaks down to HTO and CO2. That is the carbonic anhydrase. Metabolic acids include citric acid, pyruvic acid, and lactic acid. Acid buffers are weak acids and its base. And an acid buffer would be bicarbonate. As you can see from the picture, carbonic acid breaks down into CO2 and HTO and is excreted by the lungs. Through cellular metabolism, acids are produced. CO2 and H2O become H2CO3, and that is carbonic acid, which again goes to the lungs. Cellular metabolism also produces H's, which are acids, metabolic acids, which go to the kidneys to be excreted, and the kidneys excrete them as metabolic acids. Age-related differences. Infants have several physiological differences worth noting. An infant has a much greater percentage of total body weight attributed to fluid, which is 75%, compared to an adult's fluid volume, which is 58%. More extracellular fluid than intracellular fluid occurs in infants, and an immature renal system that is inefficient to excrete a sudden acid load occurs in infants. In addition, an infant's metabolic rate is twice that of an adult, and the fluid exchange ratio is far greater than that of an adult. These differences place infants more at risk for acidosis, as well as fluid and electrolyte imbalances, compared to older children and adults. Older adults have a reduced size of the kidneys, and function of the kidneys is decreased, which plays a critical role in maintaining acid-base balance. Despite this age-related gradual loss of nephrons, the kidneys of the older adult typically are able to manage their role in fluid, electrolyte, and acid-base balance under normal circumstances. However, older adults have reduced renal reserve. They are less able to excrete a large acid load through the kidneys, and their ability to compensate may be less effective. This makes older adults more susceptible to acid-base disturbances as well as to fluid and electrolyte imbalances. Variations in context are referred to as acid-base imbalance, of which there are two major categories, acidosis and alkalosis. Each of these categories has two underlying subtypes, respiratory and metabolic. When these conditions are developing, the body attempts to manage the changing acid-base balance through the corrective and compensatory responses described previously. This picture summarizes the corrective and compensatory responses to disrupted acid-base balance. Again, conditions of too much acid are called acidosis. Conditions of too much carbonic acid is called respiratory acidosis. Conditions of too much metabolic acid is called metabolic acidosis. Conditions of not enough acid are called alkalosis. Conditions of not enough carbonic acid is respiratory alkalosis. Too little metabolic acid is called metabolic alkalosis. If the pH falls abnormally low from too much acid, both the lungs and the kidneys will excrete more acid, even though only one of these organs will be excreting the type of acid that is excessive. The other organ is compensating. Depending on the time course and the severity of the problem, the disruption may be uncompensated, partially compensated, or fully compensated. If a problem with the respiratory system disrupts acid-base balance and the lungs are unable to correct it, kidney compensatory mechanisms adjust the pH towards normal. It takes several days for renal compensatory mechanisms to become clinically significant. Therefore, a short-lived respiratory acidosis or alkalosis will not become compensated. Rapid treatment of an acute respiratory acidosis will correct the problem before kidney compensation can occur. On the other hand, people who have chronic respiratory acidosis or an acute episode that lasts several days do develop some degree of kidney compensation, either partial or full. Episodes of respiratory alkalosis occur from hyperventilation and usually do not last long enough for kidney compensation to occur. If a problem with the kidneys disrupts acid-base balance and the kidneys are unable to correct it, respiratory compensatory mechanisms adjust the pH towards normal. Respiratory compensation begins a few minutes after the pH becomes abnormal, so it is common to have some degree of compensation for a disruption of acid base that involves too much or too little metabolic acid. When the disruption is severe, it will only be partially compensated. In cases of metabolic alkalosis, which is too little metabolic acid, compensatory hypoventilation is limited by the respiratory drive for oxygen so that full compensation usually does not occur. It is important to realize that even if compensatory mechanisms do not return pH to the normal range, they do prevent pH from becoming more abnormal. Excessive production or intake of metabolic acid, such as diabetic ketoacidosis, will cause metabolic acidosis. An absence of insulin will cause ketoacids, and the kidneys are overwhelmed. This occurs also in alcoholics, malnutrition, starvation cases, and ingestion of boric acid, aspirin, methanol, or antifreeze. It can also occur with a thyroid storm. Altered acid buffering is a loss of bicarbonate, which equals metabolic acidosis, such as when you have diarrhea, you lose bicarb in the excretion of the fluids and your body becomes acidotic. As far as a gain of bicarbonate would cause metabolic alkalosis, which is an ingestion of too much baking soda or IV sodium bicarbonate. Altered acid excretion occurs in alterations of alveolar ventilation, and this is called respiratory acidosis. This occurs in COPD, asthma, and pneumonia. Altered acid excretion through cellular metabolism. Two types of acid are excreted by two different organ systems. For this reason, altered acid excretion occurs in many disease processes that affect lung and kidney function. Carbonic acid excretion occurs by gas exchange in the lung alveoli, followed by exhalation. It is possible to decrease or increase carbonic acid excretion. People at high risk for decreased carbonic acid excretion have acute or chronic respiratory diseases or other conditions that interfere with alveolar ventilation. The cells continue producing carbonic acid, but the respiratory system is unable to excrete enough of it. The result is respiratory acidosis, too much carbonic acid. For example, people who have type B chronic obstructive pulmonary disease, COPD, or chronic bronchitis have decreased carbonic acid excretion due to structural changes in their lungs and excessive mucus production that obstructs airflow. They develop chronic respiratory acidosis. So do people of any age who have severe acute respiratory conditions such as asthma or bacterial pneumonia. Infants and small children have increased risk of respiratory acidosis with acute conditions because their airways have such small diameters. Although decreased carbonic acid secretion is the most common problem with carbonic acid secretion, it is possible to excrete excessive carbonic acid through hyperventilation. This situation causes too little carbonic acid, resulting in respiratory alkalosis. High-risk populations for too little carbonic acid due to hyperventilation include people who are hypoxic, are experiencing acute pain, or are upset and anxious. These conditions that cause respiratory alkalosis tend to be more short-term than many causes of respiratory acidosis. Excretion of metabolic acid may also be altered, either decreased or increased. People who have prolonged oliguria, which is very little urine, for any reason cannot excrete enough of the metabolic acid that their cells continue to produce. So this causes metabolic acidosis. These high-risk populations include people of any age with acute or chronic oliguric, which is very small amounts of urine, renal disease, and those with circulatory shock. Infants have immature kidneys that are not yet fully developed in excreting metabolic acid. Older adults have reduced ability to excrete metabolic acid load. These difficulties in excreting metabolic acid make them vulnerable to metabolic acidosis, especially in conjunction with increased acid production or intake. Increased excretion of metabolic acid through the kidneys can occur in people with excessive aldosterone. However, the most common condition involving excessive removal of metabolic acid from the body is vomiting, which removes hydrochloric acid. Vomiting also triggers bicarb retention by the kidneys, which alters buffering capacity and contributes to the resulting metabolic alkalosis. In summary, risk factors for altered acid excretion include respiratory or other conditions that interfere with the ability to excrete enough carbonic acid, conditions causing hyperventilation that excrete too much carbonic acid, kidneys that are unable to excrete enough metabolic acid, and situations in which the kidneys or repeated episodes of vomiting remove too much metabolic acid from the body. Metabolic alkalosis can also occur from hyperaldosteronism. Aldosterone, you should look that up, hyperaldosteronism. Factors that shift substantial numbers of hydrogen into cells can cause too little acid to be in the blood. The most common example in this category of risk factors is hypokalemia, So this means low plasma potassium. When low potassium is present, some potassium ions leave the cells and hydrogen ions enter the cells to maintain a balance of electrical charge. The result is too little metabolic acid in the blood, known as metabolic alkalosis. The primary risk factor for abnormal shift of hydrogen into cells is hypokalemia. Risk factors for hypokalemia are discussed later in fluids and electrolytes concepts. Assessment. Disruptions of acid-base balance almost result from other conditions. For this reason, assessments of acid-base status usually are performed in the context of other conditions. Take a history. The clinical manifestations associated with disrupted acid-base balance often are due to an underlying condition and associated fluid and electrolyte imbalances. Acid-base imbalances cause nonspecific signs such as decreased level of consciousness that can have many possible causes. It is critical that nurses consider presenting symptoms in the context of other current health conditions. The history focuses on the respiratory, renal, or other conditions that could cause the acid-base problem. The standard questions for any history apply and are not repeated here. Other areas to explode in the history include the following: a recent history of vomiting or diarrhea. Repeated vomiting causes metabolic alkalosis. Prolonged diarrhea causes metabolic acidosis. Use of heartburn or indigestion medications. A few days of baking soda or sodium bicarb ingestion can cause metabolic alkalosis. Recent attempts to lose weight and methods employed, like a high-fat, low-carb diet or fasting predisposed to starvation, ketoacidosis, and use of medications, dietary supplements, and alcohol. Examination. Unless the acid-base imbalance is severe, specific signs and symptoms of disrupted acid-base balance are often overshadowed by the clinical manifestations of the underlying cause. For example, in a person who has type B COPD, called chronic bronchitis, the dyspnea and excessive mucus production usually are more obvious than the mild drowsiness from partially compensated respiratory acidosis. With severe acute asthma, the chest tightness, coughing, wheezing, and use of accessory respiratory muscles and poor oxygenation typically overshadow the manifestations of acute respiratory acidosis. People who have end-stage renal disease experience many clinical manifestations from this chronic oliguric condition that predominate over lethargy from the metabolic acidosis that may occur between dialysis sessions unless it becomes severe. With substantial rapid changes of pH, such as with ketoacidosis, dramatic changes in level of consciousness can overshadow the signs and symptoms of the underlying condition. For example, a person who develops diabetic ketoacidosis typically will have been experiencing the polyuria, which is too much urine, polydipsia, too much thirst, polyphagia, too much hunger, and weight loss of hyperglycemia before the onset of ketoacidosis. These manifestations often are realized only looking back after abdominal pain and decreased level of consciousness from the ketoacidosis have become the focus of attention, and the metabolic acidosis is resolved. Page 81 in Concepts will show you a book, a page on too much acid and too little acid in your body and what symptoms it causes. Diagnostic tests include an arterial blood gas interpretation, which are called ABGs. This section interprets these diagnostic tests. The commonly used values are pH, PaCO2, which is partial pressure of carbon dioxide, bicarb concentrations, HCO3, and base excess. The partial pressure of oxygen in arterial blood is PaO2, and the saturation of oxygen in arterial blood is SaO2, which are measures of oxygenation. pH. pH is defined technically as the negative logarithm of the hydrogen concentration. H ions arise from dissociation of acids, both carbonic acid and metabolic. The H concentration is very small and awkward to write. For that reason, the pH is calculated. The pH scale ranges from 1 to 14, with a pH of 7 being neutral. Because pH is a negative logarithm, a low pH indicates a solution that is acidic, which has a high hydrogen concentration. A high pH indicates a solution that is alkaline, which has a low H concentration. The pH of the blood has a normal range of 7.35 to 7.45 in adults, which is slightly alkaline. The normal range is lower in neonates and infants. In clinical settings, the term acidemia is used when the pH declines below the lower limit of normal and becomes acidotic. Even though the blood still may be slightly alkaline, greater than 7.0, it is more acidic than the normal range. The term alkalemia denotes a blood pH that is above the normal range, called alkalotic. PaCO2 is the partial pressure of carbon dioxide in the arterial blood. It indicates how well the lungs are excreting carbonic acid, which is CO2 and H2O. The normal range of PaCO2 is 35 to 45 millimeters mercury. For adults, and it's lower in infants. Increased PaCO2 level indicates CO2 accumulation in the blood. Too much carbonic acid, caused by primary or compensatory hypoventilation. Decreased PaCO2 levels indicate excessive CO2 excretion, which causes too little carbonic acid, caused by primary or compensatory hyperventilation. Bicarb HCO3 concentration. The serum bicarb concentration indicates how well the kidneys are excreting metabolic acid. The normal adult range is 22 to 26 milliequivalents per liter. The range is lower in infants. Increased bicarb concentration indicates that the blood has too little metabolic acid. Decreased bicarb concentration indicates that the blood has too much metabolic acid. Base excess, which normally ranges from -2 to +2, is an indicator of how well the buffers are managing metabolic acid. Values less than -2, negative base excess indicates too much metabolic acid. Values greater than +2 indicate that too little metabolic acid. When people develop metabolic acidosis, clinicians may calculate other values, such as the anion gap and Stewart-Strong ion difference, to assist in diagnosing the specific cause. Clinical management of acid-base balance encompasses all clinical settings with primary and secondary prevention, as well as interventions for people with acid-base imbalances. Primary prevention for disrupted acid-base balance focuses on prevention of the major risk factors previously discussed rather than on prevention of disrupted acid base itself. For example, prevention of respiratory diseases helps to prevent risk factors for accumulating too much carbonic acid. Efforts to convince people not to begin smoking or to assist them to stop smoking, although targeted directly at prevention of respiratory disease, also indirectly prevents disruption of acid-base balance. Also, careful diabetes teaching and management helps prevent ketoacidosis, as well as other potential complications of diabetes. Teaching people how to lose weight safely without totally eliminating carbohydrates can help prevent starvation ketoacidosis, as well as achieve weight management goals. Poison prevention efforts can help prevent excessive ingestion of acids or acid precursors. Instruction regarding hand hygiene and safe food storage helps prevent diarrhea and vomiting, two common risk factors for disrupted acid-base balance. In summary, most of the primary prevention strategies aimed at specific disease processes and behaviors detrimental to health in general also help prevent disrupted acid-base balance. Secondary prevention. Screening measures to detect disrupted acid-base balance for secondary prevention are not performed in the general population. Collaborative interventions. Patients experiencing acid-base imbalance require aggressive collaborative management aimed at treating the underlying condition. If left untreated, the acid-base imbalance could be fatal. Most medical and nursing management is directed at the disease process that disrupts acid-base. In general, collaborative interventions to manage acid-base imbalances caused by an underlying respiratory condition include respiratory support. Also, acid-base imbalances caused by an underlying metabolic condition usually include fluid and electrolyte support. Respiratory support People who have too little or too much carbonic acid usually receive some type of respiratory support, such as airway management and oxygen therapy. People with primary respiratory acidosis, too much carbonic acid, the focus of collaborative interventions is treatment of the disease that is impairing alveolar ventilation. By treating the underlying cause of the disruption, acid-base balance may return to normal or at least to a more stable state. People who are hyperventilating develop respiratory alkalosis, which is not enough carbonic acid. Collaborative interventions for these people focus on treating the underlying factor, which could be hypoxia, acute pain, or acute anxiety that drives the hyperventilation. Hyperventilation, that is a compensatory response to metabolic acidosis or too much metabolic acids, should be allowed to continue while the metabolic acidosis is treated. Fluid and electrolyte support. People whose acid-base balance is disrupted by too little or too much metabolic acid usually receive fluid and electrolyte support as part of the intervention to treat the problems. For example, providing insulin and fluids to treat diabetic ketoacidosis removes the original problem and normalizes acid base. Dialysis for a person who accumulates too much metabolic acid from oliguric renal disease treats multiple aspects of the condition, including the disrupted acid-base balance. Very low pH can be fatal. In situations of very severe metabolic acidosis in which pH is dangerously low, collaborative focus expands to adjusting the pH itself. The most common agent used for pH adjustment is IV sodium bicarb, but its use is controversial. Administration of IV sodium bicarb may cause extracellular fluid volume or excess or hypernatremia and delay renal excretion of ketoacids or even lead to metabolic alkalosis from excessive administration. Monitoring for signs and symptoms of these complications, in addition to monitoring the patient's acid base, is crucial. Independent nursing interventions provide safety and comfort for people who have disrupted acid base. Safety is a high priority for patients with a decreased level of consciousness. Interventions can promote compensatory mechanisms. For example, patients who are hyperventilating in compensation for metabolic acidosis need careful positioning to facilitate chest expansion and frequent oral care to prevent drying and cracking of their lips and oral mucous membranes. Another important type of intervention is teaching culturally appropriate ways to prevent disruptions of acid-base balance or when to seek help if they have chronic problems. Which measurement of arterial blood gas indicates how well the lungs are excreting carbonic acid? Is it bicarb, PaCO2, water, or CO2? Your answer should be PaCO2, which is the partial pressure of CO2 regarding the arterial blood gas for question 1. Question 2, which measurement of arterial blood gas indicates how well the kidneys are excreting metabolic acid? In this question, the answer should be bicarb. The serum bicarb concentration indicates how well the kidneys are excreting the metabolic acid. What is the normal pH level of the blood? You should choose 7.35 to 7.45, which is number 3. Interrelated concepts. Numerous concepts discussed in the concepts book, chapter 9, have interrelationships with acid-base balance. For example, fluid and electrolytes and acid-base balance are closely related because changes in one of them can cause changes in the other. Gas exchange, perfusion, and nutrition facilitates optimal acid-base balance by allowing normal acid production, whereas alterations such as ischemia, which is cell death, hypoxia, which is not enough oxygen, starvation, and high-fat, low-carb diets can disrupt that process. Also, elimination facilitates optimal acid-base balance through acid excretion, whereas changes such as oliguria and diarrhea can disrupt acid-base balance. An individual who has disrupted acid-base balance can experience altered cognition. An example of optimal acid-base balance is a healthy person of any age. The person's acid production is balanced by acid excretion with adequate buffering. Optimal acid-base balance can also occur in a person with acute or chronic illness, such as osteoporosis, that does not seriously impair respiratory GI, endocrine, or renal function. The 4 exemplars representing acid-base disturbances are presented in box 9.3 and are summarized briefly in the following: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. There's actually 4. Respiratory acidosis is excessive carbonic acid, measured as partial pressure in the arterioles of CO2 in the blood. Cellular metabolism continually produces carbonic acid, which must be excreted by the lungs or it accumulates in the blood. People at high risk of primary respiratory acidosis have acute or chronic respiratory diseases or other conditions that interfere with alveolar ventilation. These conditions arise from problems in the alveoli or airways, such as chronic obstructive pulmonary disease and severe acute asthma, problems with respiratory muscle functions, such as Guillain-Barré syndrome, or problems with the brainstem control of respirations, such as an overdose of opioids or other central nervous system depressants. People develop mild compensatory respiratory acidosis if they have primary metabolic alkalosis. Respiratory alkalosis is not enough carbonic acid, measured as decreased PaCO2 in the blood. People at high risk for primary respiratory alkalosis are hyperventilating, which excretes carbonic acid faster than it is produced by cellular metabolism. Common causes of hyperventilation are acute hypoxia, acute pain, and emotional distress. People develop compensatory respiratory alkalosis if they have primary metabolic acidosis. Metabolic acidosis is excess metabolic acid measured as decreased bicarb in the blood. Cellular metabolism continuously produces metabolic acid, which must be buffered in the blood by the bicarb buffer system and excreted by the kidneys, or the acid accumulates in the blood. People at high risk of primary metabolic acidosis have excessive production or intake of metabolic acid. Examples are ketoacidosis and salicylate overdose, which is aspirin. Decreased renal excretion, such as acute or chronic oliguria, or loose bicarb buffers from the body, such as prolonged diarrhea. These high-risk people include those with undiagnosed or inadequately treated type 1 diabetes, chronic alcohol abuse with malnutrition, untreated hyperthyroidism, circulatory shock, acute kidney injury, and oliguric chronic kidney disease. People develop compensatory metabolic acidosis if they have a primary respiratory alkalosis that lasts for at least several days. Metabolic alkalosis is too little metabolic acid, measured as increased in the bicarb in the blood. People at high risk of primary metabolic alkalosis most frequently have excessive intake of bicarb through the use of baking soda as an antacid, receiving IV sodium bicarb, or from metabolizing the citrate in massive blood transfusions. Mild metabolic alkalosis is common with diuretic therapy. People who have prolonged vomiting excrete metabolic acid more rapidly than it is produced, while also retaining bicarb in the kidneys. People develop compensatory metabolic alkalosis if they have a primary respiratory acidosis that lasts for at least several days. This is the end of the slideshow.